late cyanosis can occur.
I'm not. When you speak about pathology of fellow, what is the abnormal physiology?
Sir, pulmonary stenosis is the most important.
That's a VST-PS physiology. Okay, what is the next physiology we can lead to cyanosis?
The TGA can lead to
transposition physiology. There is a TGA or abnormal connections of the veins. All is transposition physiology. It is transposed. Arteries can be transposed. The vein can be transposed. Transposition physiology. Right? Third,
sir, that hypoplastic left heart syndrome, LV, is not good. Or
no, that is all come under a particular category. You must know the category, the physiology which can lead to cyanosis. So we have already mentioned three. So we have already mentioned VSTPS situation. We have to tell about transposition physiology. 2 we have said. Then we have got 3, 4, and 5. Anybody who
admixture physiology, sir.
Admixture physiology. What is your name? Admixture physiology. Examples? PPVC. Another?
Common atrium.
Common atrium, common ventricle, truncus arteriosus, all are. And tricuspid atresia can be an admixture physiology because the whole blood in this patient actually comes through the left side onto the left ventricle. So it's an admixture physiology. So admixture physiology means that at least in the whole blood comes to one chamber at least. It can be a autonomous pulmonary venous connection, common atrium, common ventricle, truncus arteriosus, even tricuspid atresia is actually an admixture physiology. All right, okay, that is admixture physiology 4. Very good. Eisenmenger physiology. Patients with left to right strand, and that can become cyanotic. That is the 4th one. And the 5th one is miscellaneous, which include examples. Something which does not come under any of these category, but there can be cyanosis. Example? Anyone? Methemoglobinemia by itself cannot be considered as a cardiac abnormality. It is a hemoglobin abnormality. I agree with you that methemoglobinemia, sulfhemoglobinemia, carboxyhemoglobinemia all can give rise to cyanosis. But then we are dealing with a cardiac abnormality. Epstein's anomaly, very good. Epstein is one that does not come under any of this category. Very good. One more. Pulmonary artery venous fistula. In patients with pulmonary artery venous fistula, which does not belong to any of this category, the patient can be cyanotic. Okay. So out of these, Gaurav, out of these, which type of physiology a child can be born below?
Transposition was more likely because it was the first week, sir.
Yeah. My question is that what is of these various physiologies for the cyanosis that we have mentioned, one which will give rise to cyanosis from birth? On the first day itself, the child can...
First day is a TGA,
very good. Transposition physiology. 1, 2.
TGA answer, if severe PS is there. PST severe PS is there, can lead to severe PS is there with some patients.
No, TGA, even without BSTPS, they can be cyanotic. Of course, if they got BSTPS, it can be more cyanose.
Another admixture physiology, sir. Admixture physiology can present early.
Admixture physiology is only problem is that admixture physiology, sometimes the cyanosis may be very mild, and especially if there is a good flow, cyanosis may be very mild, and sometimes it may be detected only when the child cries or takes feed. So admixture physiology, all right, very good. What about BSTPS?
Is there children can have severe cyanosis during
BSTPS usually cyanosis. Severe base, I agree with you, especially if there's a patient is having pulmonary atresia, and sometimes the child can be cyanosed from day 1 or 2. Early cyanosis can happen, but usually in a BSTPS situation, like tetralogy fellow, what is the time period during which at which the child can turn become blue?
So by 6 weeks, 6 weeks of.
It takes anywhere from it may take
4 to 6 weeks. 4 to 6.
Anywhere after 2 weeks can go even up to 4 or 5 weeks. Why it is happening? Anybody who would like to take up the challenge? Why it is this delay?
So because pulmonary pressures are decreasing, so that can lead.
The pulmonary pressure as a cyanosis
So
is
there's
not.
fall of.
What is the reason why the cyanosis in these patients are delayed, especially BSTPS? Any one of you?
One is a progressive increase in the growth of the RVOT, sir, and the fetal hemoglobin transferring to adult hemoglobin, then the closing of the PDA, sir.
Very good. One is the presence of PDA. PDA, may I know your name, please?
Arun Kumar, sir. Arun Kumar.
Arun Kumar. Okay. Arun Kumar, where are you from?
I'm from Ramesh Hospital, Vijayawada, sir.
Vijayawada, okay. Arun Kumar, that is right. There are two main important reasons. One is the presence of a duct. The duct can provide adequate pulmonary blood flow, and the child can have adequate oxygenated blood, and cyanosis may not be evident. Second is fetal hemoglobin. What is the difference in the character of the fetal hemoglobin?
It has got high oxygen carrying capacity, sir.
Okay, it is a high affinity as well as high oxygen carrying capacity, and has got a capacity to dissociate with the oxygen very well. So, as long as the fetal hemoglobin is there, the cyanosis may be manifest. It may take 2 to 3 weeks. Sometimes it may take 4 to 6 weeks even, because the fetal hemoglobin really comes down only by about 1.5 to 2 months. What is the usual size of the PDA in a patient with tetralogy of Fallot? Is it a small, big, large? Anybody who would like to say whether the PDA, Gaurav, would you like to try whether what will be the size of the?
So it is generally large because that mascas develop later, so they can lead on to.
No. My question is in a patient with tetralogy of Fallot, what will be the size of the PDA? Is it large? Is it small? What is it?
Usually small, sir.
Usually small. Why it is
Sir,
small?
it is large.
No. Usually it is small. Why it is small? Explanation? What is the purpose of PDA in the intrauterine life? What is the purpose of PDA in the intrauterine life?
Shunting of blood from PA to aorta.
Yeah, it helps the shunting of blood from PA to aorta, because there is no need of blood flowing into the lungs, because lungs are not expanded. There is no need of any lot of blood coming to the lungs, and there is no oxygenation process in the lungs. So in the fetus, the PDA mainly helps to shunt the blood from the pulmonary artery to the aorta. That's a function of the PDA. In a patient with tetralogy of Fallot, where there is a BSTPS situation, what will be the amount of blood flowing to the pulmonary arteries?
It will be lesser.
It will be very low because depending upon
Less.
the severity of the pulmonary stenosis, the amount of blood which is flowing to the pulmonary arteries can be significantly low, and hence the need of a large PDA is not there because only a small quantity of blood flows through the PDA aorta, because the amount of blood coming through the pulmonary artery in a patient with VSD-PS is significantly reduced. So the PDA in general in a patient with tetralogy fellow is usually small. But still PDA will be there because some amount of blood can come to the pulmonary artery, maybe through the collateral flow, or maybe because of the bronchial circulation. So all these things can come to the pulmonary artery, and hence there is a need of the PDA, but PDA will be much smaller. Okay. So one thing when we look at a cyanotic child, second thing that we should look at is what is the main differentiation of cyanotic group into two categories.
Increased pulmonary blood flow and decreased pulmonary
So
blood flow.
Increased pulmonary blood flow, decreased pulmonary blood flow. Okay. Can you tell me a few cyanotic conditions where there is increased pulmonary blood flow? Few cyanotic conditions where decreased pulmonary blood flow.
Sir, increased blood flow is ASD, BSD, and TAPVC. Increased pulmonary blood flow is ASD, BSD, and TAPVC, sir.
No, ASD, BSD, PD are not cyanotic at all. That is not cyanotic congenital heart disease. I am asking you, mention few cyanotic congenital heart disease where there is increased pulmonary blood flow and cyanosis.
Increased blood flow is the tricuspid atresia, then Epstein's anomaly, TAPVC.
In all conditions where there is an admixture lesion without VSD-PS, there will be increased pulmonary blood flow. So, in a patient with trungus arteriosus, single ventricle, single atrium, total anomalous pulmonary venous drainage, where there is no pulmonary stenosis, there will be increased pulmonary blood flow.
Yes.
Second group.
Transpositions.
Okay,
TGV, hypoplastic left heart syndrome.
Transposition physiology where there is no significant VSD-PS, there can be cyanosis and increased pulmonary blood flow. Especially in the transposition of great arteries, the pulmonary blood flow is significantly increased, and that is another situation. Okay, anything else?
TAPVC.
TAPVC is an admixture lesion. These are the two important situations where there is whenever there is a VSD-PS, it becomes a low flow situation. Okay. Now, in the history, how will you differentiate from a low flow physiology from a high flow physiology? Gaurav?
Sir, from the onset of the cyanosis.
Onset of cyanosis may not definitely tell you. From the story, how will you make out whether it is a high flow cyanotic child or a low flow cyanotic child?
So depending on symptoms, sir, like if there is history of cardiac failure or a history of recurrent respiratory tract infections, that is suggestive of increased pulmonary blood flows.
Very good. So whenever there is a history suggestive of heart failure, recurrent respiratory tract infection, all those things indicate that there is an increased pulmonary blood flow. Okay, right? Yes. Decreased pulmonary blood flow. Decreased pulmonary.
Yes.
So decreased pulmonary blood flow patients,
yes,
they will have cyanotic spells.
they can have cyanotic spells. That is not a must. If it is there, that's suggestive. Okay, yes. If the child can take up a scatting position or equivalence, scatting equivalence, and there will be very little no recurrent respiratory tract infection, but the developmental milestones will be significantly delayed. So, two important points which will help us to make out whether it is a high flow cyanotic child or a low flow is that high flow is associated with recurrent respiratory tract infection and evidence of heart failure. And in a child, what are they from the history? What is the evidence of heart failure? Anybody?
Sir, decreased sucking.
I and release.
Sucrase cycle, sir.
Yes, sir. It release and okay, very good. Yes, what else?
Forehead
Forehead
sweating.
sweating,
Oh, forehead sweating.
Forehead sweating.
Yes.
and there will be failure to thrive, sir.
Failure to thrive. Tachypnea. Recurrent tachycardia, recurrent respiratory infection. All those, and also child has got unexplained crying, especially when in the lap of the mother or the grandmother, child suddenly cries, and when the child is put on the shoulders, the child calms down. So child prefers an upright posture. While a child with the low pulmonary blood flow will be comfortable in a squatting equivalent. What is squatting equivalent position? What is squatting equivalent?
Sir, Mohammed preparing that.
What do you mean by squatting equivalent position? Squatting, of course, squatting can happen only in a child who has started walking around, running around. But even before that, in the early postnatal life itself, these patients with a low pulmonary blood flow try to assume some position which is known as the squatting equivalent position. What is that?
The flexing of the hip in the knee joint and
Okay, flexing of the upper limb joints as well as lower limb joints.
knee joint.
And child attains that position and child gets a good relief. Gaurav, what is happening in when the child is squatting or having a squatting equivalent? How it is beneficial?
Sir, the peripheral that in afterload is increased, sir.
Yeah.
So the blood is sent from to the pulmonary circulation.
Very good. And in a squatting position, there is an increase. So there is kinking of the arteries, resulting in increase in the afterload, and hence the more blood flows from to the pulmonary artery, and hence better oxygenation. Very good. Two.
Sir, more of the splanchnic blood flow will go, which is more oxygenated.
Okay. The more what is the most oxygenated venous blood in our body?
Sir, renal, sir.
Renals.
Sir.
Renals. Renals requires very little oxygen. Renal kidney is an organ where its function is only to filter the products of metabolism, and it has got very little need of oxygen. So the venous return from the kidneys are highly oxygenated, and also even splanchnic blood, other venous return from other splanchnic organs also are more oxygenated, and hence more oxygenated that can return to the right side of the heart in a static position. So what is the advantage? What is the advantage? When more oxygenated blood comes to the right side, what is the advantage?
Yes, so more oxygenated will go to the pulmonary side, sir, leading on to less of sinus.
No. When it goes to pulmonary side, whatever is the blood going to the pulmonary side will get oxygenated. There is no problem. But when there is more oxygenated blood coming to the right atrium and into the right ventricle, whatever is the blood shunted from the right ventricle to the aorta is more oxygenated,
Yes.
and hence sinus will be much less. It is not that the blood going to the pulmonary system is going to matter very much, but it is the blood which is shunted will be more oxygenated and there will be less of desaturation. So that is the advantage. So squatting is always for two important functions. One, it increases the peripheral resistance, and hence the right left shunt comes down. More blood will flow to the pulmonary system. And two, more oxygenated blood from the splanchnic area is returned to the right side of the heart, and hence whatever is the blood is shunted from the right ventricle to the left ventricle and to the aorta is more oxygenated, and hence systemic blood flow remains more oxygenated. Okay, now let's read, Gaurav. Let us go to the history now.
The history of presenting illness. Child was born full term of a non-scientific parents.
Okay.
Parents were not told about any cardiac lesion in the baby.
Okay.
But grandmother noticed bluish discoloration. Yes, sir. Grandmother noticed bluish discoloration of the lips of the baby on crying and breast sucking in the first week
Very
of
good.
life. Child was very low noise on crying.
Okay.
Breast sucking was weak. Child was taken to a pediatrician who said that child is having a heart lesion and needs assessment by a cardiologist. However, the child was taken to a cardiac center only by 1 year of age, and child's growth was delayed. Turned over by 6 months and sat up by 1 year, sir. Sir, around turning over starts by around 4 months, sir, and sat and the child may be sitting by around 8 months, sir. So around 2 months delay is there,
Okay.
sir.
6 months. Six
Around
months
2 to 3 months
6
delay
months.
is there, sir.
Oh,
6
okay.
months, yes, sir. 2 months to 2 months, and his bluish and his blueness progressed over few months, and child was blue even at rest. Sir, and this means that the pulmonary pulmonary hypertension is set in because child is blue even at rest. That
No, don't conclude that is pulmonary hypertension. We have to give an explanation.
Okay,
This progressed over. You read the history, then you think an answer. Don't come to conclusion immediately. This bluishness progressed over few months, and the child was blue even at first. Okay, right? Yes, go.
On crying, the child used to attain. On crying, the child used to attain flexed limbs position. It was told to the parents that the child is having a heart disease which is not operable and only medical treatment is required. He started walking by 3 years of age, and on hurried walking, the child used to squat. He used to get cough and cold periodically, from which he used to recover slowly. One per 2 to 3 months interval. By 4 years of age, child started to improve, and his blueness came down, and his squatting also came down, sir. No history of cyanotic spells, no history of loss of consciousness or convulsions. No, he used to have complaints of headache periodically, gets relief by itself. No history of vomiting, no history of edema legs. Parents noticed thickening of the fingertips by 6 months of age, which was steadily increasing. He had been advised for blood forming tablets, sir.
Okay. So now let us discuss the story. Is any volunteers to discuss the story? Somebody would like to discuss the story, and Gaurav has read the story. Is anybody who would like to discuss the story? Otherwise, Gaurav can discuss the story. Any volunteers who would like to discuss the story? Anil, Dr. Wadi, are you around there? Anybody would like to? I can guide you how to discuss the story. Anybody would like? Many of you answered questions very well. I'm quite sure that you should be able to discuss without any difficulty. Okay, Gaurav, then you will start with the discussion. First point to look at is that the child has got cyanosis, no doubt. So is it a high flow situation or a low flow situation?
So most probably low flow situation, sir.
Yeah, it is not most probably, it is a low flow situation. Well, there is no, from the history, there is no evidence for us to suspect that there is a high flow situation. But there are plenty of points to say that it is a low flow situation. Child had low crying, development was delayed, but not very much of a recurrent respiratory tract infection. And also the child used to attain squatting equivalent positions. And also when the child started walking around, the child was attaining squatting positions, and the child used to get relief. All those things indicate that child is having a low flow situation. Low flow situation. Okay, very good. The child is having a low flow situation. One. Then because of the squatting, what is the low flow situation the child is having? Most likely it is a
pulmonary stenosis, sir. Pulmonary stenosis.
TPS situation. Okay, right. But it is a TPS situation. What do you mean by recurrent respiratory tract infection? What is the number of respiratory tract infection? What do you mean by recurrent respiratory tract infection? for you to say it is abnormal?
So more than 2 to 3 episodes in 2 months.
2 to 3 episodes in 2 months.
So correct.
Any one of you?
Correct definition.
In 1 year, sir.
1 year?
Sir, more than 6 episodes in 1 year, or LRTI requiring IV admission and IV antibiotics.
Very good. That's the answer. So, recurrent respiratory tract infection means 6 or more. Up to 6 can be taken as normal. More than 6 in the first year of life, and more than 4 in the second year of life. Second year of life, it actually comes down, and more than 4 is abnormal. While in the first year of life, up to 6, or a lower respiratory tract infection requiring hospitalization and intravenous administration of antibiotics, also taken as an evidence of a major respiratory tract infection. Okay, very good point. Yes. This
Sir, 6 episode of what's upper respiratory tract infection, or
only not be, at least one should have a ideally 6 means it is a lower respiratory tract infection, out of which one may be at least requiring hospitalization with intravenous antibiotic.
thank you, sir.
Okay, so as the age advances, the respiratory tract infection also comes down. Regarding scattering equivalent, what is the age during which there can be scattering equivalent, and at what age it disappears?
बोले इतनी रिक्वायरमेंट ही नहीं है, आपका पेट भर जाता है, 3 घंटे जाता हूँ अस्पताल में, बाकी अपना टाइम में बोले मरीज देख लेता हूँ.
Can somebody who is talking switch off? Can you please mute yourself?
ठीक है, और मरीज देख लेता हूँ, और बाकी मैं और मेरी वाइफ है. मैं कहता तेरे बच्चे.
Hello, somebody who is talking, can you mute yourself so that you are not disturbing others? Somebody who is talking to patient, or somebody whose voice is audible to us, you can mute yourself so that you are not disturbing others. Okay, so what is the age in which there can be the squatting equivalent, and at what age usually starts disappearing or becoming less common? Usually it starts appearing only by about 3 to 4 months of age, and usually gradually comes down by about 5 to 6 years. It can still be present, but it becomes less significant. Okay, if you look at in this patient, Gaurav, from the story, what are the other conclusions that you can draw? Do you think there is a straightforward?
There's a gradually increase.
Two things have happened.
There's a gradual increase in cyanosis.
Okay, there was a gradual increase in cyanosis.
And and by 1 year of age, he is cyanosis even at rest is there, sir. That is
Okay, yes.
And by 1 year of age,
what does that mean?
Sir, means that there's increase in PS, pulmonary stenosis.
Very good. There is a decrease in the pulmonary blood flow, and it's quite possible that the pulmonary RV outflow obstruction has become more severe, or sometimes it might have become complete obstruction to the pulmonary blood flow. A patient with severe pathology of fellow can progress to even pulmonary atresia stage over a period of time. So it is quite possible that child had a progression of disease process. Or second, maybe that the child, when the child grows, if the pulmonary blood flow also does not increase, cyanosis can automatically become more. So it need not be that the child had initially pulmonary stenosis and then subsequently it became pulmonary atresia. It is quite possible the child might have had pulmonary atresia, and then as the child grew, there was need of more and more blood to different organs, and the cyanosis became more pronounced. But then something happened. Child started becoming better. What is the thing which I can make the child feel better? What can be the physiology?
Sir, presence of hello.
Oh,
Sir, I'm audible, sir.
You are audible, but
I'm audible. Hello.
Yeah. Can you see you are audible, but can you see my slide?
Yes. Yes, sir. Slide is visible, sir. Slide is visible.
Okay. Oh.
Sir, history I've already told. So can move forward.
So just a minute, let me get the slide sharing.
Okay.
Something happened so that let me get back. I'll do the whole thing again. Otherwise, just a minute.
Okay, sir. So that was case number. Okay, sir.
Oh, can you see the slide now? Okay. Now,
Yes,
in this patient, after a short period in which child deteriorated, started improving. What might have happened?
Sir, there must be, sir, a reversal of shunt due to increase in pH. Sir. That is why symptomatically improved, but clinically his symptomatic improvement is there, sir. Due to reversal of the shunt, right to left, now right.
Now, what do you,
Sir, to increase pH, sir.
what do you mean by that? Reversal of the shunt means?
Sir, first was left to right shunt, sir, and now due to increase in pH, sir, that now RV will supersede the LV, and so we have reversal of shunt from right to left. Previously it was left to right, now right to left.
No, so you are saying that this is a more of like a Eisenmenger physiology, but there is no evidence of an increased pulmonary blood flow for us to believe that there was a first initially left to right shunt, and then the patient developed pulmonary artery hypertension and right left shunt. Here the problem is child is blue from early childhood, maybe even the first week. Then we thought of the possibilities. What are the conditions in which there can be cyanosis from early part of the life? The child steadily deteriorated, became more and more blue, and then by about 1 year or 2 years of age, the child had recurrent episodes of squatting when he is exerting, and then child started improving, where the cyanosis slightly came down, the squatting episodes came down. So, what can be the physiology which
Yes, yes, sir.
resulted in this thing?
Sir,
Anyone of you?
collaterals could have developed, sir. Collaterals
Yes,
could have
yes,
developed.
yes. The child who has got a significant reduced pulmonary blood flow situation, they get collateral blood flow, and the collaterals can become bigger. More and more
Yes.
collaterals can come to the pulmonary artery, and that can result in more pulmonary blood flow, resulting in less oxygen, more oxygenation, and cyanosis, and other symptoms also can gradually come down. So, what are the collaterals which can reach the pulmonary artery system? Which are the
Major pulmonary arteries, MAFCAS, sir. MAFCAS there.
MAPCA. MAPCA. What do you mean by MAPCA?
Sir, major pulmonary artery.
Major aortopulmonary collaterals.
What do you mean by
Major-
MAPCA?
Major aortopulmonary collateral.
Yes, major aortopulmonary collateral arteries. MAPCA. If you want to use the word MAPCA, it is major aortopulmonary collateral arteries.
Arteries.
Okay. So, which are the areas from collaterals develop into the pulmonary system?
So from that,
There are three types of MAPCA, sir.
Okay.
One is developing from bronchial arteries, type 1.
Very good.
Type
Okay.
2 is from arch, and type 3 is from branches of the aortic arch.
Okay. So there are three types of MAPCA, and sometimes MAPCA can arise even from the coronary arteries. It has been described that MAPCA can come from the coronary arteries also. See, originally it is always bronchopulmonary, and then gradually they develop a lot of collaterals from the aorta, especially descending thoracic aorta, and its main branches, even from the common carotid and even coronaries, there can be collateral flow. So there are three types of MAPCA. Very good. Yes. So the MAPCA becomes more and more. That can give rise to more of pulmonary blood flow and will result in lesser cyanosis. In addition to the site of origin, the MAPCA can be another type. What is that second type?
arch of
The MAPCA can be one. It depends upon where it joins. For example, the MAPCA, if it joins a pulmonary artery, and the blood reaches the pulmonary artery and then perfuses the lung. Some of the MAPCA may actually directly go and supply the lungs.
Segment of
A segment of the lung. And these MAPCAs are known as end arteries. And it is very important to recognize these end arteries. MAPCA which directly goes and supply the lung, a portion of the lung. Why it is important?
so post surgery they can lead into complications, sir. If
Yeah.
we are
Yes.
During surgery, we need to unifocalize this.
Yeah, that's right. But the problem is that the end artery type of collateral flow should not be ligated or closed, because if you ligate or coil or close these vessels, that can end in pulmonary infarction. So it is very important to recognize the type of the collaterals that we are having and how they are, what is the physiology of the collateral flow, whether it is supplying the, whether it is anastomosing to the pulmonary arterial system or it is directly going and supplying a segment of the lungs. So it's important to find out that. Okay, so from the story we can conclude that this small child most likely is having a low pulmonary blood flow situation. It is also, there is a clue that the child was, the parents were told that the child is having a condition which is not operable, only medical treatment is possible. So what are the conditions that you can think about?
the development of pulmonary arterial hypertension leading on.
No, but here so we are thinking of a low flow situation, and hence the pulmonary arterial hypertension is not a high probability. What can be the situation where the parents were told that child may be inoperable?
Sir, hypoplastic pulmonary arteries.
Beg your pardon?
Hypoplastic pulmonary arteries.
Yes, especially the pulmonary atresia with hypoplastic main pulmonary artery. It's a situation where the child may not be surgically amenable. So whenever there is a clue that here the child was not surgically, child was having a lesion which is surgically not amenable, you should always think of the possibility of pulmonary atresia, and where there is a main pulmonary artery is the most important structure that you should look at before you think of any corrective procedure. So especially absence of confluence, the main pulmonary artery confluence is not there, then that type of patients, it may be almost difficult to operate, and sometimes only medical management, or sometimes even palliation may be difficult, but these are the group of patients where the surgical intervention is extremely difficult or not rewarding. So we have got a clue that this child may be having some situation where the child is not operable. Okay, so we have also, so what are the conclusions that you have drawn from the story?
So first, it is a cyanotic congenital heart disease, sir.
Very, very good.
And there is the decreased pulmonary blood flow. And third, and so there is a developmental delay of around 2 to 3 months.
Okay. No,
And
not to 3 months. There is a developmental delay. Maybe
yes, sir,
if the
development.
child starts walking, started walking only at 3 years of age. Normally, a child walks at 1 year of age. So there's a delay. Okay, yes.
And sir, there was an increase in cyanosis from by 1 year of age. The child is cyanosed at rest also.
Okay. So
And
obviously the child is having a significant desaturation. Yes.
yes, and by around 4 years of age, he started having improvement in his cyanotic spells. So there is an indication that he may have developed major aortopulmonary connection, sir.
Collaterals. So you should think that the child has got his pulmonary blood flow has improved, and most important reason for increase in the pulmonary blood flow is through the aortopulmonary collateral flow. Okay. Now, what do you mean by cyanotic spell? Or anybody, what do you mean by cyanotic spell? And in what type of patients you get cyanotic spell, and what is the treatment? What is meant by cyanotic spells?
Whenever the child is put into exertion, there is an paroxysmal increase in the rate and the depth of the breathing associated with increased cyanosis. There may be associated altered consciousness also, sir.
Very good. The child, especially during activities or in the early morning time, where there is a sympathetic surge, that can result in increase in heart rate, increase in bluish discoloration, and child turns extremely blue and may become disoriented, and so in severe cases even it can throw a conversion.
Can lead to seizures.
Seizures. Okay. What is the mechanism? Is it anywhere related to severity of, in the common situation that you get is in VSTPS, especially of the infundibular type of obstruction in tetralogy of Fallot? Is a cyanotic spell an indication of the severity of tetralogy of Fallot?
Tetralogy of Fallot is always of severe severity. It only depends upon the pulmonary blood flow and the balance between the systemic vascular resistance and RVOT impedance.
Very good. I am asking you a question. A child is having recurrent episodes of cyanotic spell. Another child, no episodes of cyanotic spell. Does the cyanotic spell tell you that that child most likely is having a more severe form of tetralogy of Fallot?
No, sir. It depends on the dynamicity of the RVOT obstruction.
Very good. That's
if it is dynamic obstruction, then there is cyanotic spells. If it is fixed obstruction, there is no cyanotic spells.
Now they can have cyanotic. Most of the children with tetralogy of Fallot has got some degree of dynamic obstruction, but the activity of the child is important. Usually, the child with mild form of tetralogy of Fallot will be more active and more physical activity, and that child actually is more prone to develop cyanotic spells. Cyanotic spells will not tell you anything about the severity of tetralogy of Fallot. Very often, it is seen in milder forms of tetralogy of Fallot. And cyanotic spells usually disappears by 3 or 4 years of age. Usually it starts only after a few months, and usually completely disappears by usually 3 to 4 or 5 years of age. And what are the mechanisms? What is the reason of these children developing cyanotic spell? Explanation.
There are 3-4 mechanisms, sir. First is hyperresponsive respiratory centers.
Okay, very good. What do you mean? Explain that. What do you mean by that?
Sir, because of the hypoxia, the respiratory centers are more vulnerable. When there is increase in the right to left shunt, there is again decrease in the hypoxia, and the respiratory center gets activated because of the hypoxia, and this vicious cycle continues.
Okay, very good. The respiratory center stimulation. Okay, right. Second.
Then there is increase. There is followed theory of there is increase in the RVOT obstruction. That again lead to the.
No, due to what? You have to explain why it is happening.
Because of the sympathetic overactivity.
Okay, the sympathetic overactivity. That is why it is very frequent in the early morning time when the child wakes up and starts crying. There's a sympathetic sympathetic activity, sympathetic stimulation, which can actually cause the RV outflow obstruction, dynamic RV outflow obstruction, resulting in actually total cessation of the pulmonary blood flow. Okay, right. What third mechanism?
There is Porter's theory, which says that there is a stimulation of mechanoreceptor in the RV, which causes the cyanotic spells.
That's a less significant cause. Another is reduction in these children immediately go in for metabolic acidosis, peripheral vasodilatation, peripheral resistance comes down, and so the stimulation of the baroreceptors in the right ventricle. But the first two are the sympathetic stimulation and the peripheral vasodilatation are most important, followed by respiratory center, the respiratory abnormal respiratory response, and also the RV pressure, high, sudden increase in the RV baroreceptor mechanism. Okay, very good. And what will be the management?
Management of cyanotic spells, sir. First is we have to calm the child. We have to keep the child in mother's shoulder in knee chest position.
You should even you can hold the baby in a knee chest position. You need not put you make the baby in a knee chest position, in the prone position, knee chest. Okay, very good. Yes.
Then we can start on the oxygen.
Okay, very good. If the child is improving with this alone, I think that's enough. Nothing need be done. Otherwise, you have to, when the child cyanosis is increasing, you have to start the child on oxygen. Very good. Yes.
We have to calm the child. If it is not possible, then we can do some sedative like morphine.
Very good. Next is that if the oxygen is given, child is still very restless, you have to give morphine because restlessness increases the risk of cyanotic spells. Okay, so you have to sedate the child by giving intravenous morphine. Yes.
Then if
beta blockers we have to give, sir.
Beg your pardon?
IV beta blockers we can give, sir.
Yes.
To what is the most sympathetic activity and decrease the heart rate?
Yeah, it is intravenous beta blockers. It has got multiple actions. One, sympathetic activity can come down. It can increase the peripheral resistance, and the heart rate also can come down. So, what is the most ideal beta blocker?
Propranolol, sir. Propranolol.
Usually,
propranolol is the best beta blocker. And what is the dose?
The 0.25 to 1 milligram.
0.1 mg per kg, sir.
Okay, 0.1 milligrams per kilogram body weight is the dose. And by all these mechanisms, most often you will be able to save. And sometimes if the response is poor, then we should also give intravenous soda bicarb. Because one of the reasons for these patients continue to have cyanotic spell is because of the metabolic acidosis. And that has to be reversed by giving intravenous soda bicarb. So if the patient is having metabolic acidosis, whatever may be the medications and the manuals that you do, child may not improve. So it's extremely important. If the response is poor or slow, you should always reverse the metabolic acidosis by giving intravenous soda bicarb. So these are the things that you do to save a child who is having a cyanotic spell. Cyanotic spell usually is occurs in a VSTPS situation where there is an infundibular problem. It should be dynamic. So dynamic obstruction is the main reason for patients to develop cyanotic spells. And tetralogy of Fallot is the most important situation where there can be cyanotic spell. And the cyanotic spell does not tell you about the severity of the tetralogy of Fallot. What is the thing which decides the severity of the lesions? In the tetralogy of Fallot, what is the thing which decides the severity of tetralogy of Fallot? RVOT obstruction. RVOT obstruction is the most important single thing which actually decides the severity of the tetralogy of Fallot. Okay, right. So now let us go to the next aspect, that is physical exercise. Any doubts about the story that we have discussed so far? Okay, so now we'll go to the next aspect, physical findings. Okay, right. This is the okay. Gaurav, read.
Yes, sir. Past history, sir. There is a
full-term normal
vaginal delivery was there, sir. Cried immediately. No history of maternal infection or drug intake during first trimester of pregnancy. Family history, sir, there is one elder sibling boy, normal, no history of congenital heart disease in the family.
Okay, right. There is nothing special. So we'll go to the physical findings. Okay, right. Okay, right. Yes.
Sir, on examination, sir, child is not dysnic, no dysmorphic features, no external anomalies, central cyanosis is there.
Can you tell me one or two dysmorphic features which is associated with congenital heart disease?
High arch palate and
can you tell me a few dysmorphic features which is associated with certain syndromes which you have congenital heart disease associated? Yes.
Elfin faces, sir, elfin faces and high arch palate.
Okay. So tell me few syndromes. You need not go to the description of each syndrome.
Holt
column syndrome is associated with what? Holt-Oram syndrome is associated with what? And what is the abnormality in Holt-Oram syndrome?
AST, BST.
ASD, not BSD, ASD. It is a forearm abnormality. Forearm abnormality associated with ASD. What? Two, three, very quick. Dysmorphic features.
Down syndrome.
Down syndrome is associated with what?
Lesion, most common AV canal defect.
Total AV canal defect. Total AV canal defect is the most frequently associated heart lesion in Down syndrome. Very good. Third, another?
Algeli syndrome.
Okay.
Down syndrome.
What is associated with?
TOF and VSD.
Okay. Two or three more. Common one.
DiGeorge syndrome. DiGeorge syndrome.
DiGeorge syndrome. Yes, very good.
Associated with conotruncal anomalies.
Turner syndrome.
Yes.
Williams syndrome.
Turner syndrome. Then this Williams syndrome.
Williams syndrome.
Then
Ellis van Creveld syndrome.
Ellis van Creveld syndrome. Then Marfan syndrome. There are many conditions where a dysmorphic feature may give you a clue to the internal disease. Okay. So always you should look for any dysmorphic features. This child did not have any dysmorphic features. Okay, go ahead.
Sir, no external anomalies were there, sir.
Okay.
No external anomalies. Central cyanosis was there, and which mildly increases on exertion. Oxygen saturation.
No, not mildly increases. It is mild increases on exertion.
Yes, sorry, sir. Mild increases on exertion.
Why the cyanosis is mild, but increases on exertion. Why does the cyanosis increase on exertion?
Sir, because of decreased blood flow to pulmonary side.
Why there is a decreased pulmonary blood flow when there is an exertion?
During exertion, there is decrease in the peripheral vascular resistance.
Very good. When the child exerts, the peripheral vascular dilatation occurs, and there will be more of right and left shunting, resulting in decrease in the pulmonary blood flow. So the cyanosis becomes more severe on exertion. So if the child is having mild cyanosis and you are in doubt, you should make the child exercise mildly and look for cyanosis again. Okay, right? Yes.
The oxygen saturation is 82% in all the four limbs. Clubbing is present in all the four limbs. Parrot beak clubbing is there, grade 4. No edema of dependent parts. Pulse rate is 90 per minute, regular. High volume. Non-collapsing, no radionuclear or radiofemoral delay. Blood pressure is around 100 by 60 millimeter of Hg in right upper limb and 110 of mercury systolic blood pressure in the left lower limb. JVP is not elevated above the sternal angles.
Okay. So from this, what are the conclusions that you can draw?
Sir, no failure signs are not there, sir, because
no, the child is not in heart failure. Very good. Yes.
Yes. And sir, JVP is also not raised, so right heart failure is also ruled out, sir.
All right. Yeah. When you say there is no evidence of heart failure, both are included. You cannot say right heart failure, left heart failure. No evidence of heart failure, so both are included. Yes.
And sir, cyanosis is severe because the grade 4 clubbing is there.
We are not saying about grade 4 clubbing, and parrot beak clubbing is there. There is nothing. No mention about grade 4 clubbing, but cyanosis is not very severe because the cyanosis is only mild.
The coarctation of aorta is not there, sir, because there is no radial or radiofemoral delay, sir.
Are you strongly suspecting coarctation of aorta in this child?
No.
No, sir. Just ruling out, sir.
All right, yes. No, but because when you discuss, I think your discussion should be based on the findings that we have. There are many conditions, but you need not bring all conditions to discussion. The discussion should be more focused and oriented.
Yes, sir.
What do you think about this high volume pulse?
Aortic runoff is there.
Aortic runoff is there. So what are the situations where there can be aortic runoff in a patient with cyanotic congenital heart disease?
Aortopulmonary collaterals.
Aortopulmonary collaterals, very good.
PDA,
very good.
and in operative cases, functioning BT shunt.
Yes,
Functioning
case, if there is a BT shunt, very good.
functioning
And also,
BT shunt.
these patients can have aortic regurgitation.
In TOF also it is possible.
Yes, in TOF also,
Without
especially patients with pulmonary atresia can have aortic regurgitation more frequently. What is the reason? And what is
Because the biventricular output will be going into aorta, so aorta will be more dilated.
Very good. When both the right and the left ventricle eject blood into the aorta, and there is a steady increase in the size of the aortic annulus, and the valve becomes insufficient, and the patient can develop aortic regurgitation. What is the incidence of aortic regurgitation in pulmonary atresia?
5 to 10%.
Yeah, not little more than that, 10 to 15%. In a patient with pathology of fallow, especially in adult, it's 5 to 10%. But in pulmonary atresia, it is slightly more, 10 to 15%. Very good. So pulmonary atresia is some pulmonary regurgitation, aortic regurgitation can be considered. Another condition where there can be high flow and high volume pulse is truncus arteriosus. But of course, the truncus arteriosus is a high flow situation, so it does not come here. But whenever if you are asked a question about cyanosis and a high volume pulse, you can always think of truncus arteriosus also. So here, our explanation may be one, child may be having major aortopulmonary collaterals. 1, 2. We should also carefully look for is there an evidence of aortic regurgitation also? Okay, right, yes.
But sir, signs of AR is that peripheral signs of AR is not there, sir. Peripheral signs.
That means it may not be severe aortic regurgitation. Usually, the aortic regurgitation associated with pathology of fallow as well as pulmonary atresia may not be very severe. So it only means that it is not severe aortic regurgitation. I mean, just thinking it may not be there, but we have to look at when we get a finding, we should think of all possibilities. Maybe only related to the major aortopulmonary collaterals, because that can give rise to high volume pulse because it is an aortic runoff. Okay, very good. So now we'll go to further.
Yes, sir. On inspection and palpation, sir, apex beat felt in the fifth left intercostal space on the mid-clavicular line, localized impulse, and the parasternal
lift.
Yes, the parasternal lift is present. S2 is palpable in the second right and left intercostal space close to the sternum. There is no thrill.
Okay.
Parabdominal, no.
No, not parabdominal. No. Now let us discuss this. Inspection, palpation. Don't hurry. See, at every stage you should think. Then only you can come to a diagnosis. So what are things are here? What do you mean by is the patient is a fifth left intercostal space on the mid-clavicular line? Is it it is an LV type of apex or RV type of apex, or is it both RV and LV?
Sir, it is a localized impulse, so more of a
RV type of.
No. Localized impulse is more suggestive of
LV type of.
LV type. It is an LV type that you get more localized apex. So from the impulse, it seems that there is some degree of LV enlargement. So what are the conditions in which there can be LV impulse in a cyanotic congenital heart disease?
Sir, single ventricle.
Single ventricle, very good. Then
hypoplastic left heart.
No, hypoplastic left heart will not have LV.
Truncus arteriosus.
Truncus arteriosus, very good. One more.
Tricuspid atresia.
Tricuspid atresia. One more. Large pulmonary arteries, especially maybe man-made shunt, especially in a patient with central shunts. What are central shunts?
The central shunt. TG is the central.
Water stunts, sir.
And
Water
port shunt.
Water shunt.
And water shunt is from where to where, and port shunt is from where to where.
So port is from descending aorta to the
Left pulmonary artery. LPA.
Left.
Water shunt is from ascending to
thoracic aorta to the left pulmonary artery. Now these are not being done, but it is only it's of importance, historical importance. Now these shunts are not being done. Well, now what we do is actually even Belloc-Taussig shunt is not done. We do a modified Belloc-Taussig shunt, which is known as a Gore-Tex shunt. What is the disadvantage of Belloc-Taussig shunt? Belloc-Taussig shunt.
it is end-to-side shunt, sir. So
Yeah.
this flow to the arm is compromised.
Yeah, so it is a end-to-side anastomosis, so you have to compromise the subclavian artery. And now what we are doing is a Gore-Tex shunt. What is a Gore-Tex shunt?
It is side-to-side anastomosis of subclavian to the
It's a Gore-Tex is a material used to anastomose, and it is side-to-side anastomosis connecting subclavian artery to the corresponding pulmonary artery, and that saves the subclavian vessel, and you get the required benefit also. Okay, right. So here it can be localized impulse. It can be because of the aorta pulmonary arteries are large, or we have also discussed that whether the patient is having some degree of aortic regurgitation. All those things should come to your mind when the impulse is localized. It may indicate a more of LV impulse than of a right ventricular impulse. Okay, parasternal lift present means
the right ventricular hypertrophy is there, sir.
yeah, there is some degree of right ventricular impulse, and so it seems that the patient is having both right and the left ventricular involvement. Okay. S2 palpable in the second right and in the left ventricular space. What does it mean?
So aortic, most probably aortic. Because,
what are the situations in which you can get a palpable S2?
So first is pulmonary arterial hypertension.
Very good. It is pulmonary arterial hypertension. That is a situation where, especially the VST PS situation or any Eisenmenger situation, you can get palpable S2. Very good. Yes.
Sometimes PS also we can. PS.
Yes.
L-post aorta, palpable P2 will be there.
Yes. Anteriorly placed aorta. When the aorta is more anterior, and then the S2 becomes palpable, as can occur in pulmonary atresia, or it can occur in transpositional great arteries, L transposition, all situations where aorta is anterior and close to the chest wall, then S2 can be palpable. Very good. So S2 palpable does not always mean pulmonary arterial hypertension, but there is a likely possibility. But when it is palpable, you should always think that it may be because of the anteriorly placed aorta. Okay, right. Yes. Okay, right. So here now coming to percussion. Gaurav?
So no abnormalities detected on percussion, sir. No abnormalities.
What are the abnormalities that you can get in percussion?
Sir, if cardiac size we can, sir, if we can, if we can percuss the cardiac size, sir, that we can cardio.
Very good. You can look at the right border of the heart. Enlargement of the heart to the right side can be detected by finding the dull note on the right side of the sternal border. Okay, right. What else?
Dull note.
Dilated large
in case of PH, sir.
Dilated pulmonary artery or aortic aneurysm in an adult, all those can be suspected if you get a dull note in the second right or left intercostal space. If it is on the right intercostal space, it may indicate a dilated aorta, and if it is in the left second intercostal space, it may indicate a dilated pulmonary artery. Okay, so dullness in these areas may give you a clue to the dilated vessels underlying that intercostal space. The pulmonary artery on the left side and the aorta on the right side. Can you tell me one situation where the aorta can be near the region of the pulmonary artery?
R post aorta.
Very good. In L transposition, aorta can occupy the position of the pulmonary artery. Okay. Right, go ahead. Right, yes. Auscultation.
Sir, on auscultation, sir, S1 is normal.
Okay.
Best audible at the apex. S2 is single and loud. Best audible at the second right intercostal space close to the sternum. And sir, EC.
Ejection click.
Ejection click is present with ejection. Yes, ejection click is present, which is constant, well audible in the second right intercostal space close to the sternum. Okay. There is no S3 or S4. There is a continuous murmur at the first and second intercostal space in the infraclavicular area, increasing on hand grip. High pitched, loudest at second space or the second. The second is loudest at the second
sound.
Like loudest at second sound says no evidence of heart failure.
Okay. So what are things that you can conclude from these findings? So the second sound is single.
Single S2 is single means that PS is there, sir.
No. It does not mean. So you have to think of what are the situations where there can be single second sound. Tell me situations where there can be single second sound.
First is the PS.
No. PS. Why should there be a single second sound? PS usually gives rise to word splitting of second heart sound. Why did you say it is single second sound in PS?
Top, sir.
PH.
PGA.
PDA.
No, PDA does not give rise to single second.
PDA, no, sir. TGA. Transposition of great arteries.
Okay, transposition of great arteries. Why it is single second sound in transposition of great arteries?
Sir, aorta is anteriorly placed.
Yes.
So pulmonic sound gets diminished, sir.
Yes, this pulmonary artery is posterior and the sound may not reach the chest wall. So only the aortic component may be audible. So it can say there are many situations which can give a single second heart sound. One.
Yes, sir.
Second heart sound. Second heart sound A2 and P2 occurring together. Example.
Calcific AS, calcific.
Wait. I'll teach you one by one. A2 and P2 occurring together so that it is a single sound.
Pulmonary hypertension, sir.
Yes, VSD Eisenmenger. In VSD Eisenmenger, it is A2 and P2 occur together, so there will be a single second heart sound. 1, 2. A situation where the aortic component is loud and the pulmonary component is so feeble that the aortic component is only audible. Example?
TGA, transposition of great
arteries or tetralogy of Fallot, where the second heart sound is especially pulmonary atresia or second, even in associated with pulmonary stenosis, tetralogy of Fallot, the pulmonary component is so feeble that it is almost not recognized. Third, single valve giving rise to single sound. Example?
Pulmonary valve.
Pulmonary atresia and
Top with absent pulmonary valve.
Pulmonary atresia would be more correct because there is no valve at all. In that one, there can be sometimes some rudimentary thing, but here there is no valve at all. So the other one also is right. Absent pulmonary valve, pulmonary atresia, and one more.
Absent aortic valve, sir.
Truncus arteriosus. Truncus arteriosus is another example. And third abnormality is that there is a murmur which is so prolonged that one of the sounds is masked inside the murmur and you are hearing only one sound. Example? The murmur submerged, so one sound is submerged inside the murmur.
Yes.
Very severe PS, sir. Very severe PS.
Very severe PS or severe aortic stenosis.
Severe AIS.
The murmur is so prolonged that the one component, for example, in aortic stenosis, the pulmonary component, and in pulmonary stenosis, the aortic component will submerge inside the
Murmur.
murmur. So you know it is not audible. Another reason is that the sound, especially in a very thick chest wall person, sometimes the pulmonary component may not be audible, especially if it is associated with some mechanism where the sound is not easily transmitted, like emphysema at the chest. Sometimes the pulmonary component may not be audible. Another mechanism is that, as somebody was telling, when one of the valves is calcified. When the valve is calcified, that can give rise to a situation where that sound is almost inaudible. Example, calcified.
Contributed to calcific aortic stenosis.
Calcific aortic stenosis. In patients with calcific aortic stenosis, the second sound, the aortic component of the second sound may not be audible at all. So there are many mechanisms which can give rise to single second heart sound. So we have to think of the possibilities. What do you mean by ejection click, which is constant? What is meant by ejection click? And he said that it is a constant ejection click.
The one which is not showing respiratory variation.
Okay, the ejection click which does not have any respiratory variation is known as a constant ejection click. And tell me situations where you can hear a constant ejection click?
Vascular clicks, sir.
Vascular clicks are constant clicks, yes.
And atrial septal aneurysms, ventricular septal aneurysms, then abstinence anomaly.
No. When you are extension anomaly, does not. What do you mean by ejection click? Click must be related to the ejection of blood. Then only it is ejection click.
Valvular click in pulmonary artery hypertension, sir.
Yes, sir. One is a vascular click, which can happen in patients with pulmonary artery hypertension, systemic hypertension, in patients with aortic aneurysm. All can have a vascular ejection click. Valvular ejection click.
Pulmonary stenosis.
Pulmonary stenosis.
Which shows phasic variation.
Pulmonary click, pulmonary ejection click due to pulmonary valve stenosis is actually inconstant or phasic. What do you mean by inconstant or phasic ejection click?
It increases during expiration, sir. Reduces during inspiration.
Yeah, during inspiration, the ejection click may become very faint or even completely disappear. That is classically audible in pulmonary stenosis. What is the mechanism? Explain the mechanism.
During inspiration, there is increased RVEDP, so there is a diastolic opening of the pulmonary wall, or the pulmonary wall will doom towards the pulmonary artery in the diastole due to increased flow into the RV, sir.
Okay, so what happens is that during inspiration, there is an increase in the venous return to the right side of the heart. And when the more blood reaches the RV, because in a patient with pulmonary stenosis, RV is already hypertrophied, result in significant elevation of the RV diastolic pressure, especially end diastolic pressure, which can even actually go above the pulmonary artery diastolic pressure, resulting in doming and opening of the pulmonary valve. And hence, during the RV systolic phase, there is no more opening of the valve and there is no ejection click. So in patients with pulmonary stenosis, you can get non-phasic or inconstant ejection click. There is one situation in the vascular click in the pulmonary artery can be phasic. Can anyone of you tell me one click on the pulmonary vascular on the pulmonary side, which is a vascular click which can be phasic?
IDPA, sir.
Idiopathic dilatation of the pulmonary artery. In patients with idiopathic dilatation of the pulmonary artery, there can be a non-phasic ejection click. What is the mechanism of ejection click in valvular click? What is the mechanism of ejection click in vascular mechanism?
Vascular due to sudden doming.
Valvular, you mean valvular?
Valvular, yes.
Yes, valvular.
Vascular
It is due to
abrupt recoil.
Valvular is due to sudden doming of the stenosed valve. It tenses and produces a noise. That is the reason for ejection click. Okay. What is the reason for ejection click in vascular click?
Abrupt recoil of the vessel.
Tensing of dilated great arteries.
Oh. What did you say?
Sudden tensing and recoiling of the dilated great arteries.
Oh, that happens all in every patient. When the blood is pumped, there is a sudden dilatation and recoil. So ejection does not happen that way.
So because-
It usually happens when when the vessel is dilated.
Leaflet resonate in the arterial or reverberation of the proximal vessel part of the vessel.
Very good. Normally, also when the aortic valve and the pulmonary valve opens, it's a small noise produced. But this noise is so feeble and so low that it is not audible for human ears. In patients with dilated aorta or dilated pulmonary artery, when the valve opens and a small noise is produced, it reverberates and resonates, and it becomes audible for human ears. That is the mechanism of vascular ejection click. A vascular click, maybe aortic or pulmonary, that you have to look at. Okay, right, yes. He's having what else? Gaurav, go ahead.
Yes, sir. Sir, there is a.
It's a continuous murmur.
Yes, sir. There is a continuous murmur at the first and second intercostal space in the infraclavicular area, increasing on hand grip.
Yes. What is the evidence that increasing on hand grip means?
Sir, there is a hand grip is causing increase in that afterload, sir. That is causing increase in the pulmonary blood flow, sir. That is the cause of increase in this. This is a fistula murmur. This is the MAF cause, sir. There is major. There is aortopulmonary collaterals are there, sir. That is the cause of this continuous murmur in the first and second intercostal in infraclavicular area, sir.
Okay, hand grip increasing the murmur obviously means secondary to increase in the cerebral resistance, the flow through the flow which causes the continuous murmur is increasing.
Yes.
And the common situation where this can happen is in when a patient with cyanotic child is when there is a collateral flow from the aorta to the pulmonary artery. So it indicates major aorta pulmonary collateral arteries.
Yes.
Okay. So what are the mechanisms which can give rise to continuous murmur? There are 6-7 mechanisms where there can be continuous murmur. Can any one of you tell me the mechanisms which can result in continuous murmur? Any one of you? First mechanism is when there is an aortic runoff, blood flowing from aorta to a low pressure chamber. Examples?
EDA, AP window.
AP window. Man-made shunts.
RSOV.
RSOV. This aorta pulmonary collaterals. All these things come under that category where there is a blood flowing out of the aorta. Right, one. Two. Second, another mechanism.
AV fistula.
AV fistula, artery venous fistulas. Examples? Pulmonary artery venous fistula, systemic artery venous fistula, all can give rise to continuous murmur. That's the second mechanism. Third mechanism?
High to low pressure shunt can sometimes.
Beg your pardon?
Sir, high to low pressure shunts can come sometimes.
So high to low, what do you mean by that? Example?
Also that we have given.
Continuous pressure gradient across a vessel.
Okay, continuous pressure gradient across a stenosis segment. Example?
Stenostic segment. Example, peripheral pulmonary stenosis.
Peripheral pulmonary stenosis, coarctation of aorta. Very good.
Of aorta.
Very good. Yes, another mechanism.
Pressure gradient between the cardiac chambers present both during the systole and diastole. Example, Lutter-Bacher syndrome.
Okay, not Lutter-Bacher syndrome.
Actually, it is like severe MS with small AST.
In a patient with mitral stenosis, if the foramen vein opens up, or maybe associated with a small AST, I agree with you, small AST. That can sometimes give rise to continuous murmur. That's a miscellaneous group. There can be continuous murmur. Okay, what else? in my artery to artery communication. If there is an artery to artery communication, that can give rise to continuous murmur. Example? No. PD is aorta to
Coronary to pulmonary artery fistulas.
Coronary artery fistula. No, coronary artery fistula is from a artery to a cardiac chamber. The other one is, for example, lateral flow in a patient with coarctation of aorta.
No coarctation.
That can give rise to continuous murmur. Another is from coronary artery to a
pulmonary artery.
Pulmonary artery or coronary artery to a low pressure chamber, to pulmonary artery or to the right ventricle or to the right left through the coronary sinus into the right atrium. All can give rise to coronary artery fistula. Or coronary artery is communicating with the pulmonary artery, as can happen in patients with Al Capo. Okay, right. What else? Venous sum. In patients with venous sum. And finally, turbulent flow in a vein. Can you tell me an example? Continuous murmur in a turbulent flow in a vein.
Surgically created shunt.
Without surgical treatment, sometimes in patients with total anonymous pulmonary venous drainage, where there is an obstruction, especially of the supracardiac variety, sometimes there can be an obstruction where the innominate vein opens into the superior vena cava, or the common pulmonary vein opens into the left innominate vein. Sometimes you can get a turbulent flow, and which can give rise to continuous murmur. So there are a number of mechanisms by which there can be continuous murmur. Here in this patient, looking at the situation, most likely the continuous murmur is because of due to
MAPCAS, collateral blood flow. Due to collateral.
It is a collateral flow. It is mostly because of the collateral flow from the aorta to the pulmonary artery. Okay, so it is okay. These are the any other point that we have to discuss? Okay, now we'll go to the next point. What would you like to see? ECG, X-ray. So what is our provisional diagnosis? We have to think of a provisional diagnosis.
Yes.
So
the most probably cyanotic congenital heart disease.
Cyanotic congenital heart disease. How do you say the diagnosis in a congenital heart disease? One, cyanotic congenital heart disease. Next thing.
Yes. Physiology is BSD, PS physiology.
No, you can say it's a low flow situation. It's a low flow, reduced pulmonary blood flow. You must also say whether it is a levocardia or gastrocardia.
So it is a
levocardia. Very good. Low pulmonary blood flow situation, and you also said it is a VSDPS. Why did you say it's a VSDPS? What is the evidence of PS here?
Yes, sir. The bluish discoloration was the.
No. What is the evidence of PS? How do you diagnose PS?
Sir, that
ESM will be there.
How do you diagnose PS?
So,
by hearing?
Ejection click. Yes, sir.
Not ejection click. Now, PS is diagnosed by hearing the murmur. What murmur?
Yes.
Ejection systolic murmur.
Ejection systolic murmur in the pulmonary area. You should be able to hear a ejection systolic murmur in the pulmonary area. That is the evidence of PS. Is it there? So there is no. Don't jump to conclusions. You should explain every diagnosis by the physical finding. So there is no PS there. There is no PS. So what else is there? We have thought of the possibility of aorta pulmonary collaterals. All these things happen whenever there is a
and also
pulmonary atresia.
Pulmonary atresia. There is no murmur at all. So it's pulmonary atresia, large aorta pulmonary collaterals.
No signs of heart failure.
No signs of heart failure. And we also feel that probably the aorta pulmonary collaterals are quite large because of the evidence of
continuous murmur in the second.
No. Continuous murmur does not tell us about the size of the lateral flow. It only says that there is a flow continuously occurring.
Because patient
high volume pulse, very good. And LV and the apex is localized. So there are 2 points for us to say that actually it seems that the lateral flow is very significant. Okay, so that is our provisional diagnosis. There is no evidence of heart failure. Patient is in normal sinus rhythm. Now we'll go to the next one. Okay, ECG. So, Gaurav,
Yes, sir.
the ECG, yes.
Yes, sir. This is 12 lead electrocardiogram, sir, with standardization, and I am not able to see the standardization.
All right,
here.
okay. Let us take standardization is normal. Standardization is not there, okay? Yes.
Yes, sir. Standardization is not there. First, and sir, yes, sir, no, sinus rhythm, sir, because P waves are positive in lead 2, and P waves, normal P waves in lead 1, lead 2, P waves are positive, sir. And
So,
lead,
especially say normal sinus rhythm. Okay,
normal
very
sinus
good.
rhythm, yes.
Okay, very good. Yes.
Sir, axis is around, one is equiphasic. So axis is around right axis, sir, right axis deviation.
No, it is not right axis. What is the axis required to tell something as right axis deviation?
Sir, 2, 3 AVF are positive and 1 is equiphasic. So
can you
So it's around 90 degrees, sir.
So 90 degrees is not enough. It is plus 10 to 180.
Yes, yes.
So if it is equiphasic in AVR, then it is right axis deviation.
Okay, so 90 degrees plus 90 degrees.
90 degrees. You can say the axis towards the right, but not right axis deviation. Yes, okay. Is there a right ventricular hypertrophy? Is there a left ventricular hypertrophy?
Sir, yes, sir. V1 RSR pattern is there in V1.
Yes.
And AV plus there is a sudden transition from V1 to V. Sudden transition is there, so V1 to V2.
Okay, there is a transition, but okay, well, that is a classical of tetralogy of Fallot where there is a transition from V1 to V2. But I am asking a question: is there a right ventricular hypertrophy? Is there a left ventricular hypertrophy?
Yes, sir. Right ventricular hypertrophy. Yes, sir. Yes, sir. V1, sir, more than 7 millimeter. V1R is.
Okay. Yeah, V1R is if the V1R is equal to or more than 7 millimeters, or
Yes.
R dash is equal to or more than
More than 11.
More than 15.
More than 15. More than 15. So here that is fully satisfied. So there is a evidence of right ventricular hypertrophy by looking at V1. What is there any other evidence of right ventricular hypertrophy? When you look at V2, there is a very equiphasic reflection of almost. What is the range of equiphasic reflection which will tell you that there is a biventricular hypertrophy?
45 mm. If the total amplitude in V2, V3, V4, if it is more than 45 mm.
Okay, in any one of these, V2, V3, V4, mid precordial leads is equal to or more than 45, it indicates that there is biventricular hypertrophy. Here it is 1, 2, 3, 4, 5, 6, 7, 8, 40. It's not 45. Okay, right, yes. Is there evidence of any LV involvement?
Sir, LV forces are okay, sir. V5, V6, LV forces are.
Yes, I think V6 there are LV forces. Do you expect such LV forces in the tetralogy of Fallot?
No, sir.
No. So here there is a LV forces are seen. So that indicates that something is there which has given rise to some degree of LV enlargement. Usually in the tetralogy of Fallot, in V6 you don't get an LV pattern. So here, if you have to think of LV, then we should think whether it is a the collateral flow which has resulted in a larger collateral flow resulting in LV enlargement. So that is something which you should think. Okay, right. So this patient is having evidence. ECG shows evidence of right ventricular enlargement, right ventricular hypertrophy, as well as left ventricular. Some left ventricular involvement. I can't be certain whether there is a left ventricular hypertrophy because the criteria is not satisfied. So, but I will think that it's unusual for pure tetralogy of Fallot where I don't expect an LV.
Sir, RV expression with. RV strain pattern, sir. ST is depression.
Yes, there is RV strain pattern because in V1, V2, V3, V4, all there is some ST depression indicating there is a RV strain pattern. I agree with you. Okay, right? Yes. Look at the X-ray chest. What does X-ray chest show? Gaurav, what does the X-ray chest show?
Sir, there is a right arch of aorta, right side, sir, right arch of aorta.
I can't be certain. How do you diagnose a right side aortic arch? What is the radiological evidence of right side?
Indentation on the trachea.
You have to look for the indentation on the trachea and which side is aortic arch?
Here it is not clear, sir.
It is not clear here.
Sir, it is dilated aorta most probably, sir.
Yeah, I think in the region of the aorta seems to be dilated. And there is a pulmonary bay. There is no pulmonary artery is not prominent. The aortic arch is made out by looking at the indentation of the aorta on the trachea. If the indentation is on the left side of it is a right side aortic arch. It can also depend upon the descending thoracic aorta. It is not 100%, but most often the descending thoracic aorta tells you the side of the aortic arch. In a right side aortic arch, usually the descending thoracic aorta is on the right side. In a left side aortic arch, the descending thoracic aorta is on the left side. But it is still possible that after the right aortic arch, aorta can cross to the left side, and that can result in the aorta on the left side in a right side aortic arch. So that is not 100%. But the most definite radiological evidence in an X-ray chest PA view is the indentation of the aorta on the trachea. If the indentation is on the left side of the trachea with concavity towards left, it indicates it is a left side aortic arch. On the other hand, if the indentation is on the right side of the aortic arch, right side of the trachea, and the concavity towards the right side, that indicates right side aortic arch. What is the percentage of patients with right side aortic arch in various cardiac conditions? What is the commonest cardiac condition which can give rise to right side aortic arch?
Truncus arteriosus.
Truncus arteriosus, very good. By percentage wise, truncus arteriosus. Prevalence wise, truncus arteriosus compared to tetralogy of Fowler is much smaller in number. So, but tetralogy of Fowler number is so large that the right side aortic arch by number it would be in tetralogy of Fowler. But percentage wise, almost 40 to 50% of patients with truncus can have right side aortic arch. What next?
Top with pulmonary atresia.
Top with pulmonary atresia. What is the percentage?
50. Around 40 to 50%.
No,
50%.
20. The other one is half, 40 to 50%. Pulmonary atresia is 1/3, about 30 to 35%. And tetralogy of Fowler is
20 to 25%.
20 to 25%. And also sometimes we can get right aortic arch in VST also. What is the percentage?
20%, sir, 20%.
VST?
2%.
No, sir.
Standard VST?
8%.
Yeah, less than 5%. Less than 5%. It's usually 5%. So the VST can have right side aortic arch less than 5%. Then tetralogy of Fowler around 25%. Pulmonary atresia about 30 to 35%. And truncus about 40 to 50%. So that is the percentage. So that is how the right side. So always look for right side aortic arch. What are the other anomalies which may be associated with tetralogy of Fowler? Right side aortic arch is one. Second. Beg your pardon?
So left-sided SVC can be seen. AST can be seen.
Yeah, sometimes there can be a left-sided SVC. Another is absent pulmonary artery. Pulmonary valve. Absent pulmonary valve. When there is an absent pulmonary valve, what will be the X-ray picture?
Dilated, unoriginally dilated pulmonary artery, sir.
Yeah,
main pulmonary artery will be small, but branch pulmonary arteries will be dilated.
Yes, you can have the region of the main pulmonary artery. You can have a dilated pulmonary artery segment because of the absent pulmonary valve. So absent pulmonary valve is another association. Another important association is
bicuspid pulmonary valve.
Yes, the pulmonary valve can be abnormal, bicuspid or maybe very atretic. But one coronary anatomy, which is very important.
Coronary anomaly.
LED arising from RCA.
Yeah, which one? LED arising from
LED arising from RCA, which
RCA.
crosses
LED
through
arising
the
from
RVOT.
RCA. And crossing the RVOT. So what is the significance of this finding?
Such patient
During surgery, it can get injured, sir.
Yeah, when the surgeon repairs the pathology of fellow, he has to open up the infundibulum, and in order to reduce the to improve the artery flow. And if the patient is having the LAD crossing in the infundibular region, you may injure the LAD, and that may be a detrimental. So this information is extremely important. What is the percentage of patients with LAD arising from RCA in a patient with pathology of fellow?
4%.
Yeah,
5 to 7%.
4 to 5%. 4 to 5% the patients can have a left-handed descending artery arising from the right coronary artery. Okay. So does this X-ray suggest pathology of fellow pulmonary atresia? Gaurav?
Yes, a boot-shaped heart, we can boot-shaped heart.
Yeah, I think this X-ray is consistent with the diagnosis of pathology of fellow, or it may be even pulmonary atresia. It's quite all right. Yes. Echo. What are the things that you look for in echo? Especially you should what are the things that you look for in a patient with cyanotic angle heart disease? What is the most important thing that you look for? You should look for the abnormality.
So
Yes.
VSD.
Yeah, you have to look for the abnormality to diagnose. How do you diagnose? How do you diagnose the pathology of fellow from an echocardiogram?
You have to look for the overriding of the aortomitral continuity.
Overriding of the aorta, large
less than 50%.
subaortic VSD.
Subaortic VSD.
A very small the stenotic RV outflow, infundibular obstruction, or even the valve can be abnormal. And also you should look at the main pulmonary artery as well as
whether they're confluent or not.
Pulmonary artery branches. You should look at the size of the pulmonary arteries, the main pulmonary artery as well as the pulmonary artery branches, in order to decide the surgical treatment. They are extremely important. And also echo sometimes can give you look at the LAD coming from the right coronary artery. You can always, even from echo, you can make out whether the LAD is coming from the right coronary artery, and that also can be sometimes diagnosed by looking at the echocardiogram. Okay. In hemodynamic study, what are the things that you look at?
RV pressures and LV pressures. RV
pressure and LV pressure. The most important, the RV pressure and LV pressure are not very, because RV pressure will be equal to LV pressure. That's not very important. Most important thing that you are worried about is the pulmonary artery anatomy. Whether there is a main pulmonary artery is present, whether the size of the pulmonary arteries are adequate. All those things you should look at. How can you do a pulmonary angiogram in a patient with pulmonary atresia?
So we can't do by entering into the pulmonary artery. We have to do pulmonary artery wedge angiogram.
Pulmonary artery wedge angiogram. How can that look?
Sorry, pulmonary vein wedge.
Oh, pulmonary venous wedge angiogram. Very good. What is your name?
Sir, Arun.
Hello?
Arun, sir.
Arun, oh, okay. Arun, that's good. So, you are doing a pulmonary venous wedge angiogram. Yes. And how do you do a pulmonary venous wedge angiogram in this patient?
Sir, we have to, do transeptal puncture. Transinterarterial septal puncture.
Okay, you can, if there is many of these patients may have a patent foramen vein, then you may be able to cross through that. If that is not possible, you have to do a transeptal puncture and go and wet the pulmonary vein and do a pulmonary venous pulmonary vein wet angiogram. It will delineate the arterial system. Okay. So pulmonary artery system can be delineated by doing a pulmonary venous wedge angiogram. The most important thing you should look at is the, and second thing in this patient that we should know is
Collaterals.
collaterals. We should know about collaterals. How many collaterals are there, and where are they flowing, and whether the collaterals are end arteries. Some of these collaterals may not be joining the pulmonary arterial tree. They may be directly supplying the segment of the lung. And if you block these collaterals, that can result in pulmonary infarction. So you should look at the anatomy as well as physiology of the collateral flow. Is it joining the pulmonary arterial system, or is it directly going and supplying the pulmonary lobe of the lung, or a segment of the lung, which is an end artery. If the end artery is obstructed, then that will result in a pulmonary infarction. So two important things that we should know is that one, about the pulmonary anatomy, and second is the collateral. What are the investigations which are useful to delineate these two?
CT scan we can get. So.
Oh, yes, CT scan or even better MRI. If you do an MRI is the better investigation. MRI can delineate the pulmonary artery to a large extent and also the collateral flow. But sometimes in these patients, for better delineation, you may require the
invasive aortogram.
Also selective cannulation and injection of the major aortopulmonary collateral arteries. So that also has to be delineated. What is the importance of delineating this aortopulmonary collaterals? What is the relevance?
Sir, during surgery, sir, if they are major, they will cause increased ventilation days to the patient, sir, because of pulmonary edema post-surgery, sir.
Yeah, these patients, there can be blood coming to the lungs because the blood can flow through the collaterals, and that may interfere with the surgical procedure and certain complications. Second point is that surgeon may find it extremely difficult to locate and close the collateral flow. Why?
Sir, the flow will be there in the heart, sir. That.
No, the reason is that these collaterals are arising from the descending thoracic aorta, and descending thoracic aorta is a posterior structure, and the surgeon is operating from the front, and surgeon may not be able to access the descending thoracic aorta, and hence cannot approach the collateral flow. So collateral flow, the tackling of the collateral flow can be done at a separate sitting, or it can be done by a interventional procedure. What is the interventional procedure that can be used to cut off the
coil embolization of the collaterals?
Very good, coil embolization. You can do coil embolization, and that can result in total occlusion of the collaterals. And whatever is required, you can selectively occlude the selectively occlude, and the collaterals can be cut off. Okay, now I don't have the echo. Then what is the management? Then let's come to the management. Management, first a tetralogy fellow, then quickly, what is the management of tetralogy fellow?
So here already patient has been told that medical management only in this case.
That's right, that is all right. But for a discussion, what all things can we do? Patient is having an excellent center. If the patient is having some degree of pulmonary atresia, but the main pulmonary artery is there, what can we do?
Initially the shunt, we have to establish the pulmonary blood flow. So a palliative shunt has to be done, and later we have to consider for a definitive surgery if the anatomy is feasible.
The palliative is required only if you think that the pulmonary artery is small and you want to develop the pulmonary artery. You have to give a palliative shunt, which will help the pulmonary artery to increase in size. So that can be done. And also, if the main pulmonary artery is of adequate size, then you can always give a
total corrective repair in the single setting.
no. Now, if the patient is having pulmonary atresia,
Not in pulmonary atresia, only in top, sir. With pulmonary atresia, it is stage surgeries.
Yeah. In tetralogy fellow, what is the surgical procedure? What do you do?
Sir, VST closure.
VST closure.
VST closure, and we have to and infundibulary resection.
Yeah, you have to relieve the RV outflow obstruction by repairing the infundibular
and plus or minus transannular patch depending upon the diameter of the pulmonary annulus.
Yes, you may.
If it is less than 4,
a proper transcanal patch. And surgical patient who has undergone a nephrology fellow surgery over a period of time, what is the percentage of patients requiring resurgery?
Sir, over a period of 10 to 15 years, if they survive almost, if transallular patch is done, almost all of them will require, will develop pulmonary regurgitation and eventually require some intervention for that.
Okay, what are the situations where you think that a patient following nephrology fellow requires resurgery?
If they develop pulmonary regurgitation, which is severe.
Okay, if there's a significant pulmonary regurgitation where a patch has been placed in the RV outflow, 1, 2.
The second, if they develop restenosis of the RVOT.
How do you make out whether there's a restenosis? The RV pressure is more than?
When the RV pressure becomes more than LV.
Systolic blood pressure.
No, not more than LV. No, that's not.
More than 2/3, sir.
Oh yes, more than
2/3.
Yeah. If the systolic pressure in the RV is more than 2/3 the LV pressure. Okay, third point.
Tricuspid regurgitation.
Some of the patients with severe tricuspid regurgitation will require resurgery for tricuspid annuloplasty and reduction tricuspid regurgitation. Fourth point.
Progressive symptoms.
Now, then we have to look at what is the hemodynamic abnormality. If the patient is having a
residual VST
patch is leaking.
Patch leak.
If the patient is having a VST shunt more than 1.5:1, and that patient also requires
redo surgery.
So there are 4 situations where you have to subject the patient to redo surgery. 1, pulmonary regurgitation. 2, the RV pressure, systolic pressure more than 2/3 the LV systolic pressure. 3, patients with severe tricuspid regurgitation. 4, patients with leaking or defective VST closure where the left to right shunt is more than 1.5:1. And also, some of these patients are with after tetralogy fellow surgery are high risk candidates for sudden cardiac death. Can you tell me any clue from the electrocardiogram or from the story where the patient is high risk?
Widening of QRS complex more than 180 milliseconds.
Very good, excellent. If the widening of the QRS more than 180, what?
180 milliseconds.
180 milliseconds. That's one point. Okay. Another point. Patients getting recurrent episodes of non-sustained or even sustained VT. 3 patients who are in heart failure, especially left ventricular failure, right ventricular failure. All these patients are high-risk candidates. And by estimation, if the risk is more than 3.5% per year, these patients require ICD implantation. So patients who are at a high risk of developing sudden cardiac death, ECG more than 180, width of the QRS more than 180 milliseconds, patients who are in heart failure, and also patients who have got on Holter monitoring or during some observation has got non-sustained or even sustained VT. All these patients are at high risk of sudden cardiac death, and these patients require ICD implantation. The usual teaching is that if the patient's the risk of developing a sudden cardiac death is more than calculated risk is more than 3.5% per year, that patient requires an ICD implantation. Okay, so the pulmonary atresia patients, what was the surgical treatment possible? That depends upon the extent of the pulmonary atresia. Some of these patients can have only a valve atresia. They can have a normal sized main pulmonary artery, and the valve abnormality can be opened up, and sometimes a a prosthetic valve can be kept in the pulmonary position and these patients get a good relief. This is only a very small percentage of patients where the problem is only atresia of the pulmonary valve and the main pulmonary artery and everything else is normal. The RV outflow can be repaired and these patients can have a reasonably good corrective procedure. If the pulmonary artery is, if there is a pulmonary artery is of adequate size, but of course there is a good length of pulmonary atresia, then these patients can be benefited by a conduit placement. A conduit can be RV to the main pulmonary artery, and of course the VSD has to be closed. So these are the two reasonably corrective surgical procedures for pulmonary atresia. But in those patients with pulmonary atresia, where the pulmonary artery, main pulmonary artery is not there, or the pulmonary artery branches are not large in size, they will require a palliative procedure, a shunt procedure. Many times that itself will give good relief. Okay, any doubts, any questions you want to ask?
The ecofilms we have not seen, sir. Ecofilms are not.
Ecofilms I could not get because I looked for the ecofilms, I could not get the ecofilms. Sorry, but I'll try to get.
Sir, one small doubt, sir.
Yes.
Sir, in this patient's X-ray, the apex looks upturned and RV type, sir, but clinical examination it was localized. So
Yeah. I think there can always, it may not go together. Sometimes there can be, it may not always, the whole pattern may not always follow what we think about. So sometimes there can be some variation. So, but when you are finding that some localized LV and also some forces in the LV forces in the electrocardiogram, then you have to discuss that it's quite possible that LV is not rudimentary. There may be a good aortopulmonary collateral flow that might have resulted in some degree of LV enlargement or LV dilatation, or LV is not that small as can happen in usual tetralogy. It's a discussion point.
Sir, one doubt. So you told pulmonary atresia interventions. One was conduit placement. What was the other one?
If the atresia is only valve and the pulmonary arteries or main pulmonary arteries are normal, then you can fenestrate the pulmonary, the atretic valve, and the valve can be repaired.
Okay. Thank you, sir.
Good evening, sir.
Yes.
Sir, what is the cutoff criteria for to tell collateral is a major collateral artery?
Beg your pardon? I could follow your question.
Sir, when we can show that say that the collateral artery is the major cutoff, any cutoff criteria for that major collateral arteries? MAPCAS.
Major collateral arteries cutoff. Cutoff means I can follow your question. Cutoff means
when to say it is major or when to not significant major collateral.
The collaterals which are coming from the descending thoracic aorta, the one which are coming from the main branches of the aorta are all considered major aortopulmonary collaterals. While it's coming from bronchial tree, bronchial vessels are considered as they are not major bronchopulmonary collaterals. It is actually the ones which are coming from the descending aorta as well as from the branches of the major branches of the aorta are considered as major aortopulmonary collaterals.
Okay, sir. Okay, sir. Thank you. Thanks.
Sir, could you again please explain about the importance of MAPCAS during cardiac surgery?
Beg your pardon?
Sir, am I audible?
Yeah, you're audible, clear, and very clear.
Sir, could you please again explain the importance of MAPCAS in cardiac surgery and its importance?
In cardiac surgery, if the MAPCA is there, what will happen is that blood can flow through the MAPCA into the pulmonary artery. So that can come to the left atrium and large amount of blood may come to the heart and it may interfere with the smooth surgical repair. One. Second, if the surgeon is to close the aortopulmonary collaterals, it is not possible during the corrective surgical procedure because the corrective surgical procedure is done from the anterior chest. And this MAPCA is mostly arising from the descending thoracic aorta, which is a posterior structure. And hence, a surgeon may find it difficult to approach the MAPCA. So there are two problems. Surgeon cannot approach. Two, the MAPCA will provide a lot of blood flow coming to the pulmonary artery and back into the left atrium, and it may interfere with the surgical technique, as well as it may become more difficult for the surgeon to operate because the blood-free area may be difficult to obtain.
Sir, good evening, sir. Sir, is there any role for RBOT stenting in TOF?
Beg your pardon?
Is there any role for RBOT stenting in TOF cases of TOF?
Yes. RBOT stenting is another approach to, you can do that. People have been doing RBOT stenting in order to avoid the risk of pulmonary regurgitation. And that's one of the treatment modalities. I agree with you that I forgot to discuss about that. RBOT stenting is a treatment modality which has been accepted. You are right. Any other point you want to discuss? Okay, I think so that will be all right. Now, what is the discussion you want next week? Do you want ECGs or X-ray or continue with another case? What do you want?
Next week,
Case.
You want a case discussion? Okay, we'll have another case discussion next week also. Then we'll decide whether we should. It's important for you to interpret X-rays also. The way we can have a session on X-ray, another session on pressure tracings. We have to discuss some of the pressure tracings. You should know how to interpret the pressure tracing.
So chest X-ray.
And what did you say?
So chest X-ray discussions for one session.
Okay, then we'll do that next week. We can have a chest X-ray discussion next week, and then we'll have week after next we'll go for a case discussion. We'll alternate. That would be better. So we'll have an X-ray chest discussion next Friday, and after that we'll go back to a case discussion.
Yes.
Okay. Any doubts you want to ask now? If there are no more doubts. I think it's 9 o'clock. We'll stop at this level. Okay, thank you. I think we had a good discussion, and most of you participated. Very good. Okay, we'll stop at that level.
Thank you, sir.
Okay, right. Next week we'll have an X-ray discussion.
Yes.
Okay, right. Bye.
Thank you, sir.
Okay, bye.
Good night, sir.
Good night.
Sir, can I access the recorded session later on for review?
Beg your pardon?
Can I access the recorded session for later on review for later on? Your
May I know who is talking?
This is Dr. Ashok from RML Hospital, Delhi, sir.
Now we are trying to collect all these recorded things, and once we have edited it, then we will be able to give you. Not at the moment.
Okay, sir. Thank you, sir. Thank you, sir.
Okay. Is Jinoy there?
I guess, sir, he's not there.
Okay, fine, great, no problems. I think we have finished our class, and then I'm going to. I'll be closing. Okay.
Yes, sir. Thank you so much, sir. Good night.
Okay, Siddhi, thank you so much. Thank you. I think there was no problem.
Thank you, sir.
Okay, great. Okay.